So the question of third-line therapy for pancreas cancer, and it's good that we're discussing this because this is not a setting where we have an established standard of care, but it's also, and this is the good news, that it's an increasing discussion that we have in the clinic that more and more patients are well enough to go on to and receive a second-line therapy and also be well enough to be considered for a third-line therapy. So certainly where available and where performance status permits, I mean, this ideally is a clinical trial setting because that's how we're going to define what we should be doing in this setting, and there are some trials being developed in this space. For now, outside of a trial setting, it'll depend on what people have had in terms of their prior therapies. So for example, if we take an individual who've received gemcitabine nab-paclitaxel frontline, went on to receive the NAPOLI-1 regimen, second line with liposomal irinotecan, well then we would consider logically, based on available tools, using oxaliplatin-based therapy third line. In contrast, for a patient perhaps who had received maybe neoadjuvant FOLFIRINOX and then their disease progressed, we might choose gemcitabine nab-paclitaxel as their next step. It's really their second line treatment, although front line for metastatic disease, and then liposomal irinotecan could be third line. And if that patient remained well enough, we might actually recycle some of the drugs that were used earlier in the disease phase. We're getting into less and less data there as we go down the sequencing pathway, but I think it's only good that we're discussing this topic and that we're now, as I say, I wouldn't say exclusively making a decision based on what's available second and third line, but at least thinking about how can we utilize all the tools to get the best outcome for a given individual.